Welcome to the ICU Management and Practice DigiConf Biomarkers. Our Editor-in-Chief, Professor Jean-Louis Vincent, will moderate the session. Our panelists include Antonio Artigas, Hospital Universitário Pugtoley, Michael S Niederman, Weill Cornell Medical College, Brian C Maves, Wake Forest University School of Medicine, and Joanna Poole, North Bristol NHS Trust. Let us now welcome the moderator for today's DigiConf, Professor Jean-Louis Vincent.
Hello, hello. Welcome to everyone to this session on biomarkers, a very important topic, and I'm sure you will have many people with us as always, and many people from all over the world. We will see how to use biomarkers, which ones, in which setting, and what the clinical implications are. So the panelists were already presented to you, and I will slightly change the order and invite Professor Michael Niederman from Cornell University to give an overview of biomarkers. Mike?
Well, thank you. It's really a pleasure to be here, and let me make sure I can get my slides up. Let's see. Do we have the slides?
Yes, we do.
All right, so I'm going to be discussing emerging biomarkers for sepsis, trying to get us beyond procalcitonin. The publication ICU Management and Practice had a recent article that we prepared on this topic along with a couple of my colleagues, and much of what I'll talk about is in this publication if you're interested. And I thought I'd start with a review of the potential roles of biomarkers, particularly in sepsis. And I think when you read the literature of biomarkers, it's extremely important to ask the question, what is it that the study is actually trying to do? Is it trying to tell us when to use antibiotics? Is it a bacterial versus a non-bacterial infection? How long should we use antibiotics, particularly in sepsis and pneumonia? How intensely should we treat? Do we add? Do we de-escalate antibiotics? Can it help us define the site of care? And a lot of studies, particularly in sepsis, have used biomarkers to define prognosis. Now, what would be an ideal biomarker? We'd certainly want one that's highly specific for bacterial infection, that's not affected by prior antibiotic therapy or any other antibiotic therapy or steroids. It would work in most hosts independent of the immune status. It has prognostic value. We could identify infection early in the course of illness, and the results would be available rapidly from a single serum sample. Costs would not be prohibitive, and we could follow the results serially to guide the antibiotic use and duration. Now, no perfect biomarker exists, but these are the features that we strive to identify. In the Surviving Sepsis campaign, procalcitonin was highlighted, and it was highlighted having two roles, not for deciding when to start therapy, but maybe to use it with clinical assessment to define the duration of therapy. And I think that this is probably a very important point to make, that we should not be using biomarkers to withhold antibiotic therapy in critically ill patients. That's a clinical assessment. Biomarkers may be adjunctive information, but it's very useful to have biomarker data, particularly collected serially, to determine the duration of antibiotic therapy. One of the larger ICU studies that generated tremendous interest in a biomarker like procalcitonin was the Dutch study several years ago, the SAPS study, where over 1,500 ICU patients were compared in a randomized fashion, standard care to procalcitonin guided care, and procalcitonin guidance was dictated by an algorithm, and the guidance led to less antibiotic use, shorter duration of therapy, and quite remarkably, a lower 28-day mortality. I think that this was what got many people's attention, is the concept that antimicrobial stewardship was not only valuable for antibiotic use, but it had direct patient benefits in reducing mortality, and that benefit has been corroborated in other studies. There also been an interest in using a biomarker like procalcitonin along with clinical assessment to decide when to use the ICU, so to determine prognosis. And in this study, which looked at nearly 2,000 patients with CAP in the EPIC study, biomarker procalcitonin levels were combined with clinical assessments of severity criteria. And in the extremes here, if you had less than 3 severe pneumonia criteria and a low procalcitonin level, the need for ICU care was under 5%. And if you had more than 3 criteria, 3 or more, and a high procalcitonin level, the need for ICU care was in over 40%. And so biomarkers may have some prognostic value and help us determine site of care. But we're looking for better biomarkers. And this very nice review, which our host, Dr. Vincent, was part of, highlights 258 biomarkers that are currently being investigated. Among those biomarkers, there are 26 that have been studied in clinical trials of more than 300 people. And the gold standard to which they compare to is primarily C-reactive protein and procalcitonin. And highlighted in this review are multiple biomarkers that probably have better diagnostic value in sepsis than either procalcitonin or CRP, which gives us encouragement to be looking for new biomarkers to replace the ones that we are very familiar with now. I wanted to highlight a couple of them very quickly. Pentraxin is a sepsis biomarker. It's an acute phase reactant, and it's part of the innate immune system. Levels are higher with severe sepsis than in non-severe sepsis. And in that regard, it can help us diagnose severe sepsis. But when we also look at 17 studies, there was a higher value in non-survivors than survivors, and it became a very good predictor of mortality. And that's shown here in this graphic, that again, it's an extremely good predictor of mortality. Another biomarker is presepsin, which is the soluble CD14 protein. Presepsin results when CD14, which is a toll-like receptor, binds to a bacteria, particularly the LPS of gram-negatives. And then there's cleavage of the CD14 LPS complex, either at the cell surface or internally by the phagolysosome, with release of CD14, soluble CD14, and that is presepsin. Levels of presepsin decline and with improving infection and rise with persistent infection, and persistently elevated levels may predict adverse outcomes in patients with sepsis. And again, this is graphically showing the production of soluble CD14 at the cell surface and at the phagolysosome level. A very important concept with biomarkers is that often they should be combined. And this was a study of 700 patients with infection in 5 Italian ICUs, and 5 different biomarkers were evaluated: procalcitonin, soluble phospholipase A2, presepsin, IL-2 receptor, alpha and S-trem, and the ROC curves for any single biomarker were not nearly as valuable as the combined combination of all the 5 biomarkers and the resulting ROC. And we can see from a formula here that the best ROC curve came with combining the 5 different biomarkers. And so this is another concept, and it may not be just a single biomarker we're looking for, but rather a combination of biomarkers that can particularly help us figure out the management of patients. Another interesting biomarker has been serum amyloid A, which is an acute phase reactant, and it's been particularly useful in patients with COVID. In patients with COVID, higher levels occur in patients with more severe illness, and there's a higher risk of death with higher levels. And we can see here in a number of studies, when we look at milder versus severe illness, and I've just highlighted a few here, serum amyloid A levels are particularly high in the more severe than in the less severe illness of patients. There's also tremendous need to use biomarkers in COVID-19, where antimicrobial stewardship is essential, particularly on admission, where many patients get antibiotics, but very few have documented bacterial infection. And here there's been clear evidence that many patients have infiltrates at the time of admission that are viral and not bacterial. We don't want to use antibiotics. Later on, of course, patients can evolve and develop ventilator-associated pneumonia. And we would like to withhold antibiotics early on when patients don't have bacterial infection, but at the same time, recognize the early emergence of ventilator-associated pneumonia as a complication, which can occur in 20 to 40% of COVID patients. And so there's been a lot of interest in using a biomarker like procalcitonin for this purpose to help us withhold antibiotics when levels are low on admission and use serial measurements in ventilated patients to diagnose VAP. So biomarkers can serve a number of very useful roles. I think that they've really come to the fore during COVID-19, where all of us are looking for guidance on when to use antibiotics properly for bacterial infection in the setting of a known viral infection. So that's a very brief overview of some of the key concepts for biomarker use and some of the potential applications. And I'll turn the podium back to Dr. Vincent, and we'll move forward from here. So thank you again for your attention.
Thank you very much, Michael. I think it was a very nice opening presentation, and you touched on a number of interesting things. Perhaps it's better to move on and keep our questions to the end. I will ask you how important is it to have a prognostic factor, because it was quite high in your list. And I will also invite you to dwell a bit more on the time course of these biomarkers. But you made some excellent points, including the one of combining biomarkers. Now let's welcome Professor Artigas. Antonio, you were already presented in the opening with the opening slides, so I'll give you the opportunity to talk right away and give us your overview of the field of mediators. Antonio, welcome, my good friend.
Hello, Jean-Louis. Can I have? Yeah. Do you see my slides?
Yes, we can see them very well.
Yeah. Okay. So in the next few minutes, I will just summarize the role of the biomarkers in acute lung injury and ARDS. As you know, the ARDS is a complex disease and very heterogeneous, produced or induced by different etiologies and causes that stimulate the production of different biomarkers by different cell elements. For example, you can see the fibroblast that can produce the procollagen 3, or the endothelial cells that are producing angiopoietin 2 or the von Willebrand factor. The epithelial alveolar cells, mainly the two major biomarkers are the RAGE and the SPD, and different cell elements as the polymorphonuclears, the macrophage, and the monocytes that are producing different inflammatory or pro-inflammatory and anti-inflammatory biomarkers. And finally, the hemostatic system that is represented mainly by the production of the inhibitor of the plasminogen factor, or the PI1. So these components are inducing the alveolar capillary membrane injury, the acute inflammation in the lung, and the increased permeability inducing the presence of pulmonary edema. So what is important, or what we want from the biomarkers, probably is the same as Michael Niederman told us before. We need the biomarkers for an early diagnosis, to have the possibility to have a risk assessment, to see if the disease is progressing, or to know the prognosis of the disease. And finally, the treatment response, to use the biomarkers as a guide of a therapeutic intervention. And also it's important to consider that these biomarkers should be biological possible and easy to measure and to have rapid results. In the ARDS net and in the ARMA study, they were identified different, the majority of the biomarkers that I showed you previously that were related to the outcome and predicting death in these patients from acute inflammation or endothelial injury or the procoagulant activity. In the alveolar study, the clinical factors related to the outcome were the number of organ failure, age, the cause of ARDS, the deterioration of gas exchange, the plateau pressure, and the Apache 3. And there is also a number of biomarkers that were related to the outcome. The most important, I think, is that no pasa, no? ¿Qué pasa? The most important is that when you look on the discrimination power to predict the outcome of these different biomarkers, compare with the reduced model of taking in consideration Apache 3, H, the surfactant, the fraction, and the IL-8, you see that this reduced model has an excellent discrimination power. The same when we consider the combination of biomarkers with clinical data, and when we compare the multiple biomarkers that improve the mortality prediction in acute lung injury. This paper from Caroline Calfee shows that the prediction of the death in ARDS patient is much better when we're combining clinical and biomarker, and much better than if you consider only the biomarkers by itself. It's important also to know if the biomarkers are useful to see the impact of the different treatment, especially in those patients that are intubated with mechanical ventilation. And in this figure, you can see that the plasma biomarker of SPD, RAGE, or TNF-R1, you see that the levels is lower when they are ventilated with a very protective, with mechanical ventilation, with a low tidal volume and a higher PEEP. That means that the biomarkers can be useful to see the biological response of the lung in front of different mechanical ventilation strategy. The biomarkers profiles, therefore, can be a combination of the activity of the macrophage or the epithelial damage or the endothelial damage or the production, the activity of the fibroblasts producing the collagen 3 biomarker. The combination or the analysis of these different biomarkers can give you an idea of the balance of the epithelial damage in front to the endothelial damage. And this can be very important to understand the biological changes and then to adapt our therapeutic strategy. One of the big problem and controversial problem is that when we analyze the biomarkers in the lung by the analysis of the edema fluid, compared with the systemic biomarkers in plasma, there is a completely discrepancy. This is an example, for example, of you see the pro-inflammatory activity is much higher in the lung if you compare with the systemic inflammatory response. And that means that it's important to develop new systems, new methods to understand much better the response of the lung, because ARDS, there is a compartmentalization response to the acute insult. Recently, during the last years, there is many groups are interested to study different non-invasive measurements of lung inflammation by basically analyzing the compounds of the volatile aerosolized in the exhale breath. There are different methods. You can measure by the direct analysis of the exhale gases as nitric oxide or carbon monoxide, or the exhale breath condensate, analyzing the isoprostane or the myeloperoxidase compounds. And more recently, the volatile organ compounds in the breath exhale air, looking on the isoprene, pentane, or acetane, other volatile compounds that are characteristics of this disease. The exhale breath analysis is not a new thing. This was used many years by physicians to diagnose some diseases, and now with the new technologies we are able to identify the different volatile compounds, organic volatile compounds, that to identify a specific signature that corresponds to acute lung injury. Recently, it was described other methods to simplify the analysis of the exhale air by analyzing the samples collected in the filter of the humidification system that can be later analyze these compounds that are trapped in this filter. So the volatile organ compounds in the exhale air may serve as a biomarker for acute lung injury and ARDS, and there are some recent papers that demonstrate this, and can be integrated in the analysis of the exhale air with an electronic nose, resulting in a specific breath printings. And this, I think, in the future could be very useful to have to incorporate in the ventilators to have a biological monitoring of these patients, in addition to the physiological parameters that are monitored today. In the future, I think we need to incorporate new information on the metabolomic or breathomic or proteomics. Probably are other biomarkers that could be useful to incorporate in our studies. And finally, I think it's important to how we can translate at the bedside all this information. And I think in the future we need to use or artificial intelligence system, or to develop an acute lung injury chip that include all the clinical information as gas exchange, the lung mechanics, and the some clinical data, together with the laboratory information of the biological changes that are produced directly in the lung. If we have this both information together, we can have the possibility to integrate both parameters, I mean a group of parameters, I mean clinical and biological, and to have a more precise diagnosis of patients with ARDS, and therefore to decide the better treatment of these patients, and also to evaluate the treatment response in these patients. We can identify quickly if the patient have an overstress with an increase of RAGE biomarker, with damage of an excessive damage of alveolar cells, and or you can have parameters that indicate that there is a huge pro-inflammatory response that needs probably an anti-inflammatory strategy to treat these patients. And with that, I thank you very much, and I will be happy to answer any questions at the end. And I pass again the role
Thank
to
you.
Jean-Louis.
Thank you very much, Antonio. Your talk will raise a number of questions, and I see questions from our audience, practical questions on how we could use it today. I think there is much to say about it, but time is running. And actually, your presentation was a bit suboptimal because we could see the next slide, but I didn't want to interrupt you because it would have taken time to correct it. So thank you very much. I think it was really appreciated. And we will directly move to Professor Maves' presentation. Ryan Maves is from Wake Forest University, as you heard, in Winston-Salem. So now we will focus probably more on PCT, Ryan. Is it correct?
Yes, sir. A little more on PCT, but also some novel biomarkers without a great deal of overlap with Dr. Niederman. We chose a somewhat different area of emphasis. But I'm going to talk a bit about PCT, but really I'm going to focus a little more on the limitations of PCP. And let me get my slides up. One moment. And if I may share my screen. And how does this look? Do everything look okay?
Yes, indeed. Okay.
Excellent. All right. So again, my name is Ryan Maves. Thank you so much to Professor Vincent for the invitation. I'm an infectious disease physician and faculty critical care physician at Wake Forest in Winston-Salem in the United States. These are my disclosures, some clinical trial support and advisory panel memberships that are unrelated to anything to do with biomarkers. So a friend of mine had a line that he used once that I enjoy called the Devil's Labs, where he referred to a number of commonly used assays in clinical medicine that are subject to misinterpretation, are subject to application in the wrong clinical context. Troponin, BNP, D-dimer, lactate, and procalcitonin. I've occasionally enjoyed using this reference. I once had a resident who's rounding with me who very reasonably ordered a procalcitonin on a patient under our care. And so I asked the young doctor, what did you order this test for? And he told me, he said, well, I ordered it to see if he was infected. And I looked at him and I said, well, I'm pretty sure that this febrile patient with a temperature of 39.2 degrees centigrade, a leukocyte count of 30,000 with a 10% bandemia on 2 vasopressors, I'm pretty sure he's infected. And there was no result of that procalcitonin that would convince us otherwise. And I suppose that's part of what we'll talk about as we go over some of this biomarker data relatively briefly, is to what extent do biomarkers change clinical decisions? To what extent do we act on them? Do we only act on them when we like the answer? They only act on them when they give us an answer we want? Or do they guide therapy in a way that is positive and improves care outside of the clinical trial context? So Dr. Niederman alluded to this. I'll just go over this again. What are the principal 3 uses for procalcitonin in the intensive care unit? I would argue they are 3. Determination of viral versus bacterial pneumonia as a gauge of illness severity and as a tool for determining the duration of antimicrobial therapy. Well, I'm going to argue that the first two are relatively less useful in bedside practice. The third one, I think, has some very solid data, but solid data that can only be applied really in the appropriate context. So let's start at looking at the procalcitonin as a marker of etiology in patients hospitalized with community-acquired pneumonia. This was the EPIC study that, again, Dr. Niederman mentioned. And what I would draw people's attention to in the EPIC study is this. This is from a different publication, not in chest, but in Clinical Infectious Diseases of 2017. Looking at the diagnostic characteristics for procal in patients who are initially admitted, even if you are using a very low cutoff of 0.1 nanograms per milliliter, which is considerably lower than most of our laboratories would consider for the lower cutoff, the negative predictive value for a patient admitted to an intensive care unit with severe pneumonia is 82.4%. That's the negative predictive value. So meaning there is about an 18% chance that a given patient with a low procalcitonin, a very low procalcitonin, in fact has a bacterial pneumonia despite that assay. A question we have to ask ourselves in this is, do we like those odds? Is a nearly 1 in 5 chance that a patient, a critically ill patient, in fact has a bacterial infection sufficient to withhold antibiotics? I would argue for the great majority of us, it is not. That is not a decision we would be willing to commit to in the first 24 hours of that patient's care. So how about severity of illness? So procalcitonin clearly correlates with severity of illness. That's probably part of the reason it gets a bit confounded in the ICU. Well, this is one of many studies that shows here, and this was again published this is in Critical Care Medicine, showing that procalcitonin correlates very nicely with other biomarkers in terms of safe monitoring of antibiotics. But it is also not really any different than C-reactive protein, another very non-specific biomarker. Although admittedly, the procalcitonin data sets are much larger and the prospective evidence is much stronger for procalcitonin. What about COVID? In COVID-19, this was a very nice cohort. What we have seen with COVID-19, and I think this is also largely true of influenza, that the area under the curve, the receiver operator curve of procalcitonin as a predictor for bacterial superinfection is 0.56. That is a slightly better than random odds. And what we really are seeing is that procalcitonin in the case of COVID largely correlates with disease severity. I think we can all agree that community-acquired severe COVID-19 pneumonia with respiratory failure initially presenting from the outside world into the ICU is very unlikely to have bacterial superinfection at the time of presentation, and withholding of antibiotics there is very reasonable, at least in the patient not in shock. But the utility of this particular biomarker, in addition to physiology, is sadly, unfortunately, rather limited. That doesn't mean that procalcitonin has no benefit, and I would clearly argue that it does. And one of the best validated ones, and again, we alluded to this before, the MOSES trials, the SAPS-2 trials, the ProRata trials, all looking at different ways to use procalcitonin to guide and discontinue antibiotics in patients in the intensive care unit with sepsis who are improving clinically. This is an observational study from, it was published in Chest in 2017. This was done in the United States. And I pointed out not to say that procalcitonin doesn't have benefit, but that it needs to have its benefit interpreted in context. This was a matched propensity score without regression adjustment, looking at patients who had procalcitonin guided therapy and those who did not. Again, observational study. You see there is a clear reduction, 17.3 days to 14.9 days of total antibiotic exposure in patients in this. That is shaving a good 2-3 days off of antibiotic duration in the ICU. That is not nothing. That is also still insufficient. Going from 17 days to 14 to 15 days is not good enough. That is still too much antibiotic exposure. And I think it will be interesting as our antibiotic stewardship programs evolve in our respective countries where we work, to see what is the impact of this guidance if it is implemented with a general paradigm of shorter courses of therapy. What then is the benefit to biomarkers on top of that? I think that is unknown. This is an improvement. This is not good enough. That being said, this is a very strong meta-analysis published in 2019, looking at all of these clinical trials, ProRata, SAPS-2, MOSES, and others, integrating and saying, well, what is the actual benefit of procalcitonin in terms of reductions in antibiotic durations? And the signal is consistently positive, really with only Staph aureus pneumonia being a bit vague in terms of its benefit. And that's largely due to small numbers and wide error margins. It is pretty clear that procal across a large cohort of patients does reduce, can be used, if used wisely, to reduce the duration of antibiotic therapy without a negative impact. And as Dr. Niederman mentioned, possibly reduction in mortality in our patients. So it might work, but it needs to be implemented systematically, not on an ad hoc basis. So what do we do with all this, right? What do we do with all this? How do we actually implement this into practice? Well, in addition to integrating biomarkers into a strong stewardship program, there are some novel and emerging biomarkers out there that may have some potential for us. So one is proadrenomegaline. So this is a very non-specific marker. And what it really is, it's a product of vascular endothelial cells. And the lab actually looks for a mid-region of the N-terminal portion of this. It is, broadly speaking, predictive of organ injury and death and correlates relatively well with SOFA score. Now, the question is, if it correlates with SOFA, what do I need another blood test for? Well, it does seem to predate the onset of a worsening SOFA score in patients and could be a useful early marker of high risk. Suggesting that earlier intervention and closer monitoring could be useful. This is not a biomarker of infection. This is a biomarker of organ failure, right? It does not distinguish between pathogen types. It doesn't tell between bacteria, viruses, and is not specific for infection per se. It's been validated in cardiogenic shock, in acute heart failure populations, and in the perioperative setting as well. Again, very early data, very limited, but an interesting marker nonetheless, and could be of broad interest to intensivists. Presepsin, Dr. Niederman alluded to this one. This is the N-terminal fragment of soluble CD14. This binds more or less specifically to lipopolysaccharide, to gram-negative endotoxin. And as a result, it seems to be a little more specific for gram-negative infections versus gram-positives. That's not the only thing it binds to, but it is somewhat suggestive. And as part of an integrated biomarker panel, if you have an elevated presepsin in addition to, say, another more non-specific bacterial biomarker, this could push you more into a gram-negative direction, theoretically. It is probably inadequate ruling out sepsis, but it does seem to upregulate faster than procal. Procal takes 6 to 24 hours to upregulate. Presepsin comes up faster. And this is a study comparing presepsin to procalcitonin in patients with confirmed sepsis and septic shock. And when you see at time 0, you're more likely to have a positive presepsin than you are procalcitonin. Also, like procalcitonin, this appears to decline with effective therapy and could potentially play a similar role as procalcitonin as a stewardship tool. Pancreatic stone protein is an acute phase reactant produced by the exocrine pancreas. It does seem to be relatively specific for infection. It also rises faster than procal, similar to presepsin. The data for this is largely observational, but in the chart here, this is a publication from the Annals of Surgery 2 years ago. And what it shows is that patients with genuine sepsis would get rapid increases in pancreatic stone protein, whereas patients who are merely infected, that is, say, have an infection with no organ failure, it tends to stay pretty stable. And that is a useful marker of severity. It doesn't tell you if you're infected, it tells you if you have a severe infection that puts you at risk for increased mortality. Most excitingly for me anyways, because I am a simple man and I don't like ordering extra tests, is monocyte distribution width. So this is available on routine complete blood counts that you have a leukocyte differential. An increased MDW greater than 20 may correlate well with sepsis. This is pathogen agnostic. It does not distinguish between viral bacterial diseases. This could give us potentially actionable data. This is widely available. And if prospectively validated, which is not yet the case, if we could use MDW to distinguish between sepsis versus cardiogenic shock at the time of presentation, for example, this is a sort of tool that would have potential for altering care at the bedside. It is rapidly available as well. Do note in this chart here that the area under the curve and the receiver operator curve of MDW is about the same as CRP and procalcitonin. This is not a unique tool in of itself, although its sensitivity is a little higher. That is at the cost of some specificity. There is no silver bullet, is what it comes down to. There is no blood test that will solve our problems. And I argued in the article that Professor Vincent kindly let me write for the magazine that the most useful biomarker in the ICU are the eyes, ears, hands, and brain of a skilled intensivist, right? I'm not saying that we are 100% sensitive and specific. Far from it. I am just saying that there is currently no blood test that is less inaccurate than I am. Right? We have a ways to go before that. And in the context of antibiotic shortening, Brad Spellberg, who is a professor at the University of Southern California here in the United States, in ID land has made a big push for this notion of shorter is better as a tool of stewardship. Things like procalcitonin-guided therapy clearly can play a role, but they only are going to play a useful role if we first of all embrace this. Short courses of high doses of appropriate pathogen-directed therapy. We get that right, then we'll see what procalcitonin does for us. And that is it. Thank you so much for your time. I appreciate the opportunity, and I wanted to thank my good friend, Dr. Samir Kadri Rodriguez, for letting me steal a couple of his slides.
Thank you very much, Ryan. That was very instructive. It was a very good presentation.
Thank you, sir.
We should have Dr. Johanna Poole as the fifth speaker with us, but apparently she had an emergency and she is trying to reach us before the end. We still have 17 minutes to go, and so we'll start the discussion. We are very lucky to have 189 participants with us from all over the world, and there will be some questions, perhaps focusing more on low or middle income countries as well. I mean, we'll have to speak about the costs of these markers. But perhaps, actually, Ryan, you could get the first question
Yes,
that I see from the audience. And again, I encourage the audience to write their question. I'm checking them. And the question here is a rather broad question. It is, what should I do when I see a PCT level, a procalcitonin level, which is elevated, but all bacteriological results, including culture results, are negative? Should I consider that this is an infection, but I cannot find the microorganism? Or should I think that this is due to something else than an infection?
Well, I suppose that's a great question. And I'll admit that the day that I solve that answer, I will have mastered my craft and I can retire in peace. I would answer with two responses. One is, how sick are we looking at? Are we looking at a patient in shock or respiratory failure? If a patient is in shock and respiratory failure and you have no other compelling explanation for those things, be it hemorrhage or bowel ischemia or what have you, then I think you are compelled to provide antimicrobial therapy, antibacterial therapy, until you find a better reason or until the patient improves, right? And the Surviving Sepsis campaign is reasonably clear about this, that in the patient with shock, if you cannot exclude septic shock due to a compelling alternate diagnosis, then one is compelled to treat for sepsis. And I think that is just wise clinical practice. The second thing about procals, though, is that there are things that give you what I'll call false positive procalcitonins. They're not truly false positive. The procalcitonin level is in fact elevated, but it is not elevated due to bacterial infection. So one common one in sepsis to be considered is candidemia. The immunologic response to candidemia is very similar to our immunologic response to, say, Staph aureus bacteremia. Hematologic malignancies can give you elevated procalcitonins. Acute kidney injury can give you an elevated procalcitonin. Depending on where you practice, there are some small studies out of Thailand showing that dengue has led to elevated procalcitonins, and malaria very clearly can. So considering those alternate diagnoses is another thing you're going to have to do. Some of those are non-infectious, some of those are, but that is the approach that I would take. And if the patient is doing well and not sick, I would just observe, to be honest.
Very good. Thank you. Mike Niederman, do you agree?
Well, yeah, I would add a few nuances. I mean, I agree in general, and I think it's been a great discussion. But I have to recognize that we can't, even in sepsis, where the culture will always be positive. So getting a negative culture doesn't necessarily rule out. And again, clinically, it's very hard to tell the lung inflammation. Is it infection? Inflammatory is it? So I think, again, as we've said, and as the Surviving Sepsis campaign emphasizes, when somebody's critically ill, we do not use a biomarker, even procalcitonin, as a reason to use or not use antibiotics. That's a clinical assessment. On the other hand, the other issue you alluded to earlier is that serial measurements can be very useful. And getting a high level early and watching it drop can be very informative. You'll have to figure out why that is. But again, that may be useful, again, for stopping therapy along the way. So to me, this is all information that's potentially valuable. It has to be put in context, but I wouldn't completely disregard the possibility of a serious bacterial infection just because cultures are negative when the biomarkers are high, like calcitonin. One last point I'll make, we didn't have time to talk about, is the PASS study that was done years ago where rising procalcitonin was used as an indication to intensify antibiotic therapy. That did not work out. That actually led to increased mortality. So I think it has to all be interpreted in a clinical context.
Okay, that was a bit outside the question which was raised, but Professor Artigas, you said that biomarkers could help you to diagnose ARDS. How important is it to diagnose ARDS? Does it change something to your therapy? There is no specific therapy, right?
I think that ARDS, you know very well that the definition, the actual definition of Berlin definition is not a very appropriate definition, probably because it's based only on clinical and some physiological and radiological information. But ARDS is mainly a lung inflammation, and there is no information or included in this definition. So I think it's especially for randomized controlled trials, we need to have an evidence of that there is really lung inflammation in these patients.
So it's primarily for clinical trials, you mean, but
I think
for the clinicians at the bedside.
I think it's could be the same, but for the clinicians at the bedside, you need to have a device or a system that could be useful to be applied at the bedside. And I think now in San Francisco and other groups, we are working on to develop a system that can be useful to be applied at the bedside to have an information, a quick information, and also to be used to monitorize the response to the treatment or the evolution of the lung inflammation in these patients. An example could be, for example, in COVID patients. In COVID patients.
COVID, okay.
There is a paper, but when you look on the biomarkers in these patients, initially there is a huge damage of endothelial biomarkers with a huge expression of endothelial damage, but few of the alveolar epithelial biomarkers as the RAGE. RAGE start to increase later on. And this gives you an information of what are the biological changes and how your therapeutic strategy should be done. And I think
but people cannot measure RAGE quite easily. I mean, we have people from all over the world here, and they would like, and a big question which is recurrent here is, what about the costs of all this? So Ryan, if we had to take the cost into consideration, even PCT is not that cheap. No. Would you look at the monocyte distribution width as perhaps a cheaper way to monitor patients?
Well, that does need to be prospectively validated, right? We don't actually know about that yet. I'm very excited about the possibility of it. I don't want my enthusiasm for the concept to outstrip the evidence, though. And I think that if we found that something like monocyte distribution width, which is a test we've been ordering by accident for years, it just doesn't get reported on routine CBCs, but our machines already measure this. And it turns out that it has properties and characteristics similar to procalcitonin or other biomarkers, then that would be very exciting. That doesn't exist yet, but I think we can be hopeful this is an area of future research. And in terms of supporting our colleagues in low and middle income countries, I mean, heck, in terms of supporting me, I would be excited about that. Hopeful, not ready for prime time.
Now, several of you spoke about determining prognosis, but is it important for us to have a biomarker to see the chances of survival of our patient? Are you ready to pay to get a bit more information about the prognostic value, about the prognosis of a patient? Mike Niederman, you are the first one to mention that.
I think that's a really good question. I think depends obviously on the clinical scenario, but in pneumonia, for example, site of care is related to prognosis, and determining site of care is very important and may actually impact prognosis or at least ultimate survival. So I think knowing when somebody's sick and when they need intensive care, if you can be pushed to that by a biomarker, that may actually improve outcomes. That's probably the most specific example where that information is actionable to the point that it can help patients.
Yeah, or perhaps when the patient will leave the emergency room to decide indeed whether the patient would go, well, perhaps at home, or to the regular floor or to the ICU. That could indeed help. But if the patient is already in the ICU, perhaps it's more debatable. What do you think, Antonio? You also mentioned prognosis several times.
Yeah, I think that the combination of the clinical information with some few biomarkers can improve the prognosis to determine the prognosis of these patients. And I agree with Michael that the most important is the evolution. I mean, to analyze this in a dynamic point of view. The prognosis could be different the day 0 if you compare on the day 3. I mean, and this you need to have a dynamic evaluation of these parameters. But certainly, I think the combination of a few biomarkers and the clinical data could improve our capability to determine the prognosis of these patients.
Yeah, but the question was, what do I do with it? What do I do with this information? Well, almost every day I receive articles saying, you know, we found a new biomarker being related to prognosis. I reject these papers because I don't know what to do with it. If it has the specific question of ICU admission, that may indeed be very valuable. But just to see that the patient has 80% risks of dying, what can I do with this information? I'm not sure it's so helpful.
Well, probably in outside of the ICU can be very useful to determine to transfer this patient in a higher level of care. And in the ICU can be also useful to determine the level of care of these patients. For example, a patient with an ARDS that they have a bad prognosis with a very important acute lung injury, probably you can decide to go further and to start the treatment in a high level treatment earlier, no? For example.
Okay. Ryan, someone asks, what about the patient who is on hemofiltration with dialysis? Is PCT eliminated by the system?
You know, I'm going to give you a straight answer that I am not certain. I think it depends a little bit on the system. And I'm thinking in the context a bit of not just conventional dialysis, but some of these novel hemofiltration systems that are derived for sepsis care, like the Seraph filters and Cytosorb and others. In general, patients on hemodialysis have elevated procalcitonin levels, so compared to comparator groups.
All right. Mike Niederman, you mentioned that perhaps it could be useful to separate bacterial infections and viral infections. Do you think we can really adjust our antimicrobial strategies based on PCT levels or other biomarkers levels?
I think that that's certainly the hope. And I think I've been encouraged in spite of some of the negative data that Dr. Maves presented about procalcitonin in COVID. I think some of the data, for example, from Thailand demonstrate that you could really determine prognosis and antibiotic stewardship with procalcitonin cutoff levels. And so I do think that whether it's bacterial or non-bacterial, or whether it's antibiotic need or non-antibiotic need, which may be slightly different, I think that the data are encouraging that cutoffs could be used to provide stewardship guidelines for antibiotics. And I think the COVID experience demonstrates that to a large extent.
All right, maybe another question to you and perhaps to Ryan. Someone asks in Spanish, actually, but I understand enough to translate, whether the CRP does not provide the same kind of information as far as the antibiotic de-escalation is concerned, because we agreed on the fact that this is perhaps the best, the most interesting approach of these biomarkers, but could CRP, which is very cheap, do as well as PCT, Mike?
Well, that's a hard one. And again, there's a lot of polarization about CRP. A lot of Europeans view it as the gold standard. Tony Torres's group did a very nice study where they looked at severe infection and demonstrated that CRP rises later in the course of illness than procalcitonin. So certainly early decisions may be better made with procalcitonin. Whether you could stop antibiotic therapy as reliably, again, is less clear. A lot of very strong data from Europe, but I think there's been a lot more prospective randomized controlled data with procalcitonin number one. And at least in some of the early COVID studies, it was sort of universal to see elevated CRP and much more selective to see elevated procalcitonin. So CRP may be somewhat less specific than procalcitonin.
Thank you. Ryan?
Yeah, I completely agree. The observational data certainly suggests that CRP is a good tool for antibiotic de-escalation. And I'll say, in my non-ICU job, when I'm caring for patients with deep-seated infections in my ID practice, we do, for like osteomyelitis and the like, we do use CRP for that purpose. But in terms of critically ill hospitalized patients, the procalcitonin data is just more robust. It's more, you have actual RCTs that are prospectively conducted. So yeah, I completely agree with Dr. Niederman.
But I suppose we'll agree that biomarkers should not be used in isolation to decide whether we should stop antibiotic or not. We need to associate it with our clinical evaluation, right? And integrate these signals. Antonio, do you agree as well?
Absolutely. Especially if you consider surgical patients.
Yeah, of course. Yeah, definitely. So now, Antonio, I still don't see exactly how you could use the biomarkers to adjust the respiratory support in your patients and patients with ARDS in particular. Do you think in the future we could say, this biomarker levels are increased, I should further reduce the tidal volume or further increase the PEEP level? Do you think it could guide really our respiratory support?
I'm absolutely convinced for this future view. Probably it's not right now, but could be in the next future. Because imagine that you have a patient that there is an increase of the epithelial alveolar damage because of you are stretching the lung. So probably if you decrease with a more protective mechanical ventilation or with extracorporeal CO2 removal, for example, the decrease of this biomarker will indicate you that you are ventilated the patient more properly.
But how fast would you have this answer? Do you think you can have it?
Very quickly.
Very quickly, so we could monitor it a few times a day, for instance?
Yeah, well, if you have a system that you can monitor in during 24 hours, you can have the trend during all the day. If you, for example, looking on the exhale air, if you are taking plasma samples, you can probably repeat before and after the changes of the ventilatory strategy. But the problem is that right now, the mechanical ventilation is based on physiological data.
Okay, yeah, thank you. two last quick questions because we are reaching the end of our discussion, but we have many more questions here. And one is there a different cutoff value for PCT values in oncologic patients? Let's say in patients with metastatic disease or with leukemia. Do you have any data on this? Do you have any experience? Can you comment? And the last question is, perhaps for Mike Niederman, could you use biomarkers to decide when to give corticosteroids in ARDS? Would you really look at the degree of inflammatory response right now, not in the future, right now? Would you use it as a guide to make such a decision?
Well, I can try to address the second one. I think the answer is a qualified yes. And I think in the prospective randomized controlled trial that we did with Tony Torres of corticosteroids in patients with community-acquired pneumonia, the criteria for receiving steroids was the combination of severe pneumonia and an elevated C-reactive protein. And so conceptually, giving anti-inflammatory therapy to people without inflammation doesn't make a lot of sense. And so conceptually, it does make sense to identify high levels of inflammation as a target for anti-inflammatory therapy.
That sounds reasonable. Ryan and Antonio agree?
I fully agree. Yeah,
so our time is over now. I'm sorry that we missed Joanna Poole, but again, she had an emergency and we had a little more time for our discussion. I would like to thank you very, very much and thank our 171 participants who are still with us at the very end of this hour. Thank you very, very much to all of you. Take care. Bye-bye.
Bye-bye.
Take care.
Well, thank you.
Thank you all. It was a pleasure.